Contact lens intolerance has been a major issue for decades. It is a problem that affects a significant percentage of contact lens wearers every year. Clinicians and industry partners alike are looking for the single thing that can help to keep our patients in their lenses longer and more comfortably. Unfortunately, with the advent of new lenses, solutions, and artificial teardrops, this number has remained stable. We like to ask one simple question of our patients in order to discover the root cause of our patient's discomfort. When you first started wearing this contact lens, did you feel the same level of discomfort that you're feeling now? For most patients, they say that the issue is more recent, indicating that the issue is really the ocular surface and not the lens or solution. In reality, very few patients wear an uncomfortable lens from the time that they are fit until a year or two later. We found that our patients usually return asking for improved contact lens if they feel uncomfortable upon the initial fitting. We like to solve all of our patients' issues where the lens itself is the problem by switching them into one of the newest and most innovative contact lens technologies. We always use single-use lenses when they're available in the patient's prescription, and this accounts for about 90% of our patients. When a patient cannot wear a daily lens and they note that their eyes have become more uncomfortable when they switched their contact lens solution, we switch them into a peroxide-based contact lens solution, being careful to avoid generic peroxide solutions. We see a major disconnect where the industry partners and some practitioners have elected to simply change patients into a new lens or a new solution, meanwhile ignoring the ocular surface. When in reality, if the patient's discomfort is increased while wearing the same lens, we can only blame the ocular surface. Now, we have addressed dry eye and meibomian gland dysfunction in our prior episodes, but to briefly recap, no single diagnostic test can be used to fully diagnose dry eye type or severity. Likewise, we don't have a magic pill for treatment. We utilize the tear lab to check osmolarity and find out how far beyond normal our patients' tears are. We like to utilize the Inflammadry to test our patients for inflammation, and if present, we treat the initial inflammation with steroids and usually begin our patients on cyclosporin depending on other dry eye factors. We utilize LipiFlow to assess the quality of our patients' blinks, lipid layer thickness, and health of their glands through meibography. We found that when a patient blinks partially, their contact lenses will not wet properly. When their lipid layer thickness is depressed, their tears will evaporate too quickly, and if their glands are atrophying and dilating, that they're in a stressful situation that will likely lead to further discomfort with contact lenses and possibly dropout. Please review our prior episodes related to dry eye for more details. Remember to look at the ocular surface first in your assessment of contact lens comfort. Treating our patients' dry eye initially and then ensuring that they are in the healthiest contact lens and solution will help us move the needle on dropout and ultimately improve our patients' quality of life.